It's really fun to
How's that?
you to laugh.
Do you have suggestions?
You can see that number?
No? Did you see? Did you put other?
Okay.
Is it done?
All right. Today is May 20th. We're doing an in-service on fall prevention. So let's go over these. I'm just gonna share like a really quick statistics that I pulled out online to kind of show you how significant falls are in skilled nursing. Is one of those where it's hard to prevent, but it's like one of the most costliest in terms of residents' change of condition. Residents will often fall, secondary to what's going on with them, right? They could have like an infection or something. They could have had a surgery that changed their mentation. Now their ability to comprehend certain things like safety, those are compromised just because they're now a little bit more confused, right? So let's take a look at statistics on falls. Almost half of all nursing home residents fall each year. So between 50 to 75%, which is twice the number of chances of falling for older adults living in a community setting. So that's a lot. You considering, let's just say you had 30 admissions in 1 month. Maybe you have a new admission every month. Just know that almost half of those residents are probably gonna fall within that time frame, right? What's worse, falls often go unreported, leaving nursing home residents to suffer in silence. Only 57% of all nursing home falls are reported. So that means that there are approximately 50% of the falls are not being reported. Let's say there was a fall in a nursing home and it didn't result to an injury and the patient was confused. Sometimes those things can be masked or maybe not reported. Unfortunately, in those situations, sometimes the residents do have a fracture, and we don't find out until like a week later because now the patient is having more pain, and we find out that through X-ray, because patient has had significant pain, swelling or bruising now. Now we find out that patient has a fracture or dislocated type of hip or something like that. And we've had that here previously in the last, I'd say in the last 10 years or so, where a patient fell and it wasn't reported by the nurse, and the CNA has actually reported it. It wasn't documented that it was a fall. And the CNA was like, hey, I did report that as a fall. She fell a week ago. And so maybe that was long ago. I'm not sure. Within, I think, past maybe 10 years, so it's quite a bit ago. But we did lose that nurse. So it's significant because, nurses, CNAs, we all have a license certification to protect. And if we get into some hot waters like this situation where it's dealing with patient safety, and fall is one of those where it could be considered an abuse type, if it's not being reported correctly. So yeah, we did lose that individual. Some nurses, believe it or not, and CNAs, they do lose their certifications in the process. And worse, if it's considered an abuse, you might, go to higher extent where you might face jail time if it results into a resident death or significant injury, and even monetary, even you have to pay off some of these fees and fines. Okay, roughly 1,800 individuals living in nursing home facilities die from falls in any given year. 1,800 related to falls. And considering half of these people, residents, the falls are not being reported, 1,800 is really a small number. Considering half of the residents that are falling down are not being reported. And think about it, if somebody had a fall and it's not even reported, a week later, now they have a broken hip and now they have to go to the hospital or whatnot, now they're getting more narcotics, they're gonna have a change in condition, right? So,
Remember Mary, our residents?
yeah. So we won't talk about her just because we went through so much stuff with her. And she was a special case where we were dealing with family members as well, asking them for help. They weren't helping us, giving a hand. We have care plans indicating that she was a difficult patient, and we weren't getting the assistance we needed from families as well. So it wasn't just like a facility issue that we had. It was a multi-tier level, different people that was involved. We weren't getting enough help. About 1 in 3 nursing home residents will fall 2 or more times in a year. So, if you have 20 falls that month, just know that some of those falls is related to patients keep falling down, basically. So it seems like you might have a lot of falls, but technically speaking, the ones that keep falling down are gonna keep falling down, basically. So they make up a majority of your fall. So if you're looking to prevent falls and decrease the number of falls that you have, you want to focus on the ones that falls, usually the ones that are confused, has a history of falls, right? Because they're gonna keep falling down. About 5% of U.S. adults age 65 and older resident in nursing homes, death due to falls by nursing home residents make up 20% of death in the same age group. I'm not sure if I put this sentence together correctly here. About 5% of U.S. adults age 20% of death. Oh, so 5% of the population 65 and older, they make up 20% of death in a nursing home that's related to falls. So the very few of those, so if you have 20 people that falls all the time, there's a top 5% that makes up the death because they're the one that highest for fall, and they have underlying medical conditions like heart disease and stuff like that. That makes it hard for them to kind of recover when they do fall. About 1 in 10 nursing home falls results in serious injuries. So 1 in 10 results in serious injury. On average, nursing home with 100 residents reports about 1 to 200 falls a year. Between 16 to 27% of nursing home falls are caused by environmental hazards such as equipment in the hallways. So more than 1/3 of these falls is related to something that we can prevent, basically. Maybe eyewear, maybe hearing aid. Environmental mostly is like equipments that's kind of getting in the way. Slips and falls related to like cords and stuff that's not being placed correctly, or just cluttered type of rooms, right? About 35% of injuries due to falls occur in residents who cannot walk on their own. Okay, so we know that, but 35%, putting a number on those people, on these residents that are high risk for fall, 35% are related to the ones that cannot walk, right? All right, let's talk about hazards that may cause nursing home falls. Okay, since these are things that we can prevent, right? For example, beds that are set too high, right? Residents typically who will fall or high risk for falls, if you set their bed low and they do fall and you have a bed mat, a lot of times they're gonna get away from it without, fracture. But if you forget to bring the bed down because you did your last round or whatever, that fall from now, 4 feet high now, right? It's gonna be significant. They're gonna hit their head. You're gonna break their back. You're gonna break their hip. So just lowering the bed itself is gonna help us with the fall. Falls are bad, but if they result into an injury because we kept the bed too high, that's gonna be even more significant. So we want to make sure that when we are taking care of residents that are confused or high risk for fall, they can't walk, make sure you're lowering down those beds. Okay, cluttered living spaces. This is the one that we just talked about. These are things that we can prevent after you put the resident back to bed. For example, room 33, with 32, where we have to keep the wheelchair away from her. Because once she sees the wheelchair, she wants to get up and get in a wheelchair. So she has a really poor safety awareness, right? She just wants to get in a wheelchair and get going. So that's why we have that policy, just keeping that away from her. But technically speaking, in terms of the environment, you want to keep your environment, your room, clutter free. Put away the clothes, put away the shoes, put away the wheelchair, leg rest. Those things gets in the way. Also, like cords for breathing treatment, your oxygen type, your bed, kind of tuck those underneath the bed, and those things will prevent your resident from falling down. Okay, rugs and stuff like that. You shouldn't have rugs in the room anyway.
Even the worker.
Yeah, even the workers will fall, right? Yeah, you don't want to hurt our workers. Hard to manage clothing, right? These things can prevent a fall as well, right? It's falling down. It's too baggy. It's too big, right? So we want to make sure those things are fitting correctly for the resident, because those can definitely cause of issues in terms of falls. Ineffective wheelchair brakes, right? Your resident tries to get up and it's not locked correctly, or the lock itself is broken. You wanna, those can cause falls. You wanna inform the resource nurse or put in a work order list so our housekeeper, not housekeeper, our maintenance crew can go and fix those wheelchair brakes. Okay, those are things that we can fix here, right? We can prevent from happening, occurring. Missing equipments or parts. Same thing with wheelchairs. There are things that are missing. Easy stands and stuff like that. If it's not working correctly, those can cause serious injuries. The bed itself, right? It can be an old bed. We're not looking at it correctly. We're not checking it for safety.
How come the top of the bed is never locked? Every single bed is like that.
It's not locked. The top.
It doesn't lock.
Yeah, it only.
The top of the bed.
Right.
Yeah.
So when
The
you raise the
wheel.
bed up, the wheels, you can lock the back, but
But
the head of the bed should, as soon as you raise the bed up, it should, there's a little piece of metal that goes like this, so it keeps it in place. So you should keep it in place. Yeah. If you keep it all the way down, so here's the bed, right? It goes like that. If you raise, it goes like this. If you raise it up, it goes like this, so it touches the floor. But once you raise it down, it goes like that. So now you can move the bed around, right? So you should be doing that. But you're saying that the head of the bed is not locked.
It's not.
Yeah.
Yeah, it have a lock, but it's not
But
rolling.
get rid
But
of
Yeah.
when I try to turn the rest of it, the whole thing is going.
Yeah. Oh, from the top.
roll.
Yeah. Yeah, unfortunately with these beds that we have, they're pretty good beds. They're only locking at the at the bottom part. Yeah. If we do move towards maybe locking both ends, we imagine 60 beds we have to change. So if we are gonna move that in that route, it's gonna have to be a couple years from now when we're doing a renovation. Poor lighting is significant too, right? You residents who has these Parkinson's and dementia, they see certain things, right? They will see lines as if like it's a pitfall, right? They will see rugs if it's a different color. If you have a carpet area and then you have a white, let's say it's gray carpet that's overlapping or kind of transitioning to tile. They're gonna look at the carpet because it's darker as like a hole, right? So these residents that have visual issue and hearing issues, mentation, they have Parkinson's, they have dementia, these can be significant. And lighting too, certain things, if it's too bright, if it's too dark, certain things will glare on the floor and it's gonna look like it's weird to them. They're gonna try to step over it and they will shuffle over it and they're gonna trip on their own feet, right? Glaring and then being too dark too is just, they're not gonna be able to see certain things, just because their vision is not adequate, right? So putting on those glasses is gonna be really important. Poorly fitted or maintained wheelchair, we talked about that. Uneven floors, as we talked about, certain things that will dip, or sometimes there's a divider in the floor, right? And it's a bump, and they kind of, they're already shuffling, right? They're walking as they shuffle. They're gonna bump their feet, their toes, their shoes on, and they're gonna fall down. Those are things that can create falls. That's why rugs is really important to just remove rugs away, right, from anywhere when you have patients that are having difficulty walking as it is. Unstable furnitures, wet floors are gonna be significant, right? All right, let's talk about medical. Anything else that you guys feel that would cause a fall that's preventable from on our end as far as CNAs, right? Those are hazards that we can prevent from adding to the fall. Medical conditions that may cause nursing home falls, being underweight and being overweight. Certain things those will cause falls for the resident. Epilepsy or seizure, having active hip fracture, obviously that pain, they're gonna be, they're gonna be unbalanced when they're walking. Huntington's disease, history of falls, incontinence could cause falls, right? Severe cognitive impairment, using cane or walker, these are things that could increase their fall. Wandering, right? Wearing corrective lenses, also hearing aid. If you have a patient that has difficulty hearing, those cause imbalance issues, right? Fall prevention actions and interventions. Let's take a look at some of the things that we can use or prevent falls from happening, right? We can add bedside commode, right, to kind of help the resident not only shorten that walk to the bathroom because you have a bedside commode, right? So that way, if they just want to use the bathroom at night, they don't have to walk so far away. Bedside commode is a good addition. Elevated toilet seats. Some of these residents, will fall down, sit down, and it's too low. They hurt the back or whatever. But that high toilet seats is going to be helpful. Grab bars, we know those will help, right? Low profile beds will also help with, residents that have risk for falls. Mobility aids like walkers. You have a resident that are, adamant about not using a walker, encourage them. Make sure if they are walking, they're not using a walker, give them a walker. Talk to physical therapy to try to get that implemented. Monitoring bed alarms, personal alarms, and then having night lights. Okay, we already know the bed alarms, right? Those things can notify us that the patient is moving about or gotten out of bed. But night lights, we talk about not having enough lights, but also just at night, specifically having a little bit of lighting for the resident. If you know that the patient, if you work knock shift and you know that the patient is getting up and you're not going to be able to get a hold of me or anyone that can give you a night light, talk to the resource nurse and tell them, hey, I think this patient who is oriented, she gets up on her own, doesn't call, can we add an extra night light? The rooms itself already has lights in a way, the side lights. But if you need more, absolutely we can get those in there. Okay, so those would really help. It provides reassurance to the resident, and then gives them a full view of the room in a clear way, right? Increased communication obviously is really important. If the patient's still oriented, let them know, hey, if you need help, make sure to call me. Reminder and queuing is really important. A lot of times, some of these residents, they don't, they feel kind of, they don't want to burden you because they keep calling, but so communicating with them, just like, hey, just let me know if you need help to use the bathroom. They might need that extra reminder, that you're there for them, right? We talk about eyewear, hearing aids; those can help out, obviously. And then if we take a look at the bottom here, Seacrest Village. Oh, you guys don't have this copy. Sorry. Seacrest Village Protocol for Fall Risk. What is the START program? We have that program basically. The 4 Ps, right? Anybody outside their name that has a red dot, those residents are high risk for falls. If you look at the census, more than half of our residents, there's a lot of residents in there that has a red dot. All these residents are high risk for falls. We got them on a STAR program. That means we're monitoring for the 4 Ps, right? We're monitoring to see if they have pain. We're monitoring for potting, if they use the bathroom, right? If they are parched, right? Are they hungry? They want to eat or drink, right? Sometimes, they don't want to call you, but hey, I want to get up because I'm thirsty or hungry or whatever. They're confused. They can't tell you how they're feeling, but you say, hey, you hungry? Reminding them, you need some water.
Yeah.
Those will definitely help them out. So making sure that knowing our policy in terms of residents, how do we monitor for residents that might be high risk for falls? We monitor for 4 Ps. Are they incontinent, right? They have bowel movement or urine, maybe that's sitting there for the last couple hours in their briefs, right? That can cause some very irritated skin, right? You want to be able to change them, right? Patients that are incontinent that can't, tell you that they want to get up, right? It's uncomfortable to have that bowel movement in there. So checking to see and make sure that they have, they're clean. That could make them comfortable afterwards, right? And but also if you run into a situation where the patient is very difficult and you ran out of options of what you need to do, typically what we do is that we provide 15-minute checks on these residents, right? We put them on a round. You've seen those little paper before where we check to see what the resident is doing every 15 minutes. That can really help out. And sometimes that can be acute, something short term. The patient just came back from the hospital. They are on antibiotics for infection. We're gonna put them on every, Q15-minute check, right? For 3 or 4 days or whatnot, right? Monitor or move the resident closer to the nursing station. Have the nurse put their cart outside their room. That will help as well, right? And then repositioning them more frequently, right? Checking their vitals to see if they're doing, they're making sure that their vitals are okay. Because sometimes vitals will tell you if the patient isn't comfortable, if they're nonverbal, right? All right, so let's take a look at protocol after the fall, what we do. Seacrest Village protocol after the fall. Call for help. Obviously, you want to call for help. If you notice that your resident is on the floor, you want to get the nurse in there. Don't move the resident. you want to get that assessment done to make sure that the patient didn't have any fracture. The patient hurt their neck and you moving them around is going to make it worse. Have the nurse move the resident. Okay. You can either use the call bells for help or you can yell out for help, right? Use the radio as well too for help. If patient on the floor, stay with the patient. Do not move the patient. These can increase injury, as we talked about, if you're moving patient. Check the vitals right away if you can, even on the floor if you're able to get the vitals on there. If you're waiting, especially for paramedics or whatnot, you can take some vitals on the floor there so long as the patient is now comfortable. You want to monitor for change in mentation, also monitor for increased pain or increased vitals. That could potentially tell you whether there's any kind of fracture on there, but that's mostly for the nurse as well to kind of assess to see if they have any kind of fracture. Okay, I'm going to give you guys some examples of falls that we've had in the past. Okay, that we had a resident. I'm not going to mention their name, but we had a fall on 10/12/2019, approximately 7 p.m. watching TV. Call light was activated. This patient fell because she wanted to lay down in bed, and then this time frame, I think it was PM, and the CNA put her in bed and put her at home. Go watch TV. I'll be back. Put you back in bed. This resident is used to going to bed right after dinner, but I don't know if it was miscommunicated between the patient and the resident, but certainly knowing your resident what time to go to bed is going to be important when you preventing fall, because this could have been prevented if we would have just said, hey, you know what, just keep them at the nursing station. I'll just put you to bed first. She's got another one stated she wanted to pick up magnifying glass off the floor. So it just kind of shows you an example of these patients' abilities or poor safety awareness. They know that they can't get up on their own, but they wanted to get up anyway and try to get that off the floor. A couple weeks ago we had the same thing, right? Mrs. I think 30B. She's on that specialized wheelchair. She was in her room. She was kind of moving around, and she tried to grab something, and leaned forward and fell down. Right. There was another patient on knock shift. Fell knock shift at 1:30 a.m. Walked herself to the bathroom and fell. So a lot of these patients, as you can see, are kind of somewhat like a little bit more oriented, kind of like oriented to maybe one or two, and they still feel like they can move about and they really can't. Okay. All right. Any questions on the falls there? Okay. Let's go over the test real quick, guys, in terms of falls and prevention here. Okay. Okay. List intervention to prevent falls. List intervention. Respond to all call lights and monitor all residents in my hallways when another CNA or nurses are on break. B, monitor for 4 P's: parch, potty, pain, positioning. C, being proactive with patients who are in START program. Monitor closely and respond quickly to alarms. So these are interventions that we can use. All of them are really good intervention, actually. So we're going to do all of the above. All of these are ways to prevent a fall, right? Interventions. My duty after a fall occurs. What do you think you should do as a CNA when after a fall? A, you do vitals every 15 minutes, 4 times, and then 30 minutes, 4 times, and then every hour 4 times. Write a statement for occurrence and witness if applicable.
Yep.
And then B, wait for nurses to tell me what to do.
Gonna be A.
Yeah, it's gonna be A. Those are things that we can do, like we expect, right, to be doing right after a fall. We're gonna need to take vitals. Your nurses are gonna expect, hey, make sure you're doing vitals every 15 minutes. You can do it 4 times, and then every 30 minutes. You can do it 4 times, and then every hour. Okay, until your shift ends. If the fall occurred on your shift. Okay. Usually they will give you a piece of paper and tell you, hey, this is how our vitals are going to be done. But just know that there's a frequency when you take vitals after a fall. Especially if you note that the patient fell and, or it was an unwitnessed fall, or they hit their head. These are called neurochecks, right? if a patient kind of slip and fall and hit their butt, you don't have to do these neuro checks because you know that she didn't hit her head, right? You only have to do vitals every shift. After that, she fell, so you do vitals every shift. This vitals that we do every 15 minutes, every 30 minutes, is related to a head injury. But if you had a fall and it was unwitnessed, you're gonna treat it like a head injury, right? And that's the reason why we'll be doing these vitals. Which of these patients may be at risk for falls? A new admit who is oriented, status post-surgery, and prefers her independence. B, agitated patient secondary to infection or pain. C, constipated, confused patient. All of them could be at risk for fall, right? Especially, it doesn't seem like, hey, this patient is oriented, but these patients are the ones that you feel like, oh yeah, she's all there, she'll be fine. But these are the ones that fall frequently because they still feel like they can do certain things, and I want to get up and do things on my own, and they're not used to the fact that you're weak, you're getting weak, you're gonna fall down. All right. Explain how the STAR program works and policy. STAR program, remember, that's the 4 Ps, right? You're monitoring for the 4 Ps for pain. If you look above there, if a patient is nonverbal, you're checking to see if they have any kind of, moving about. They're just squirming. If they have facial grimacing, if their breathing is different and a little higher, that might indicate that they're having pain or discomfort. Parched, you're checking to see if they're hungry or thirsty. Potty. Did they have urine or bowel movement in their incontinence pad, right? Positioning, you want to make sure that that they are being repositioned at least every 2 hours. Because if they're not, they're gonna have some pain, discomfort. They're gonna get up on their own. They're gonna move about, and they're gonna fall down. So that's our STAR program. Is really not just, hey, survey comes in. What is this STAR program mean? What do you do for these residents so they don't fall? If you say, hey, you know what, we just come in and monitor them more closely, that's not going to be good enough. You have to mention the 4 Ps, saying that this is what we do. We monitor for 4 Ps and make sure that they're not incontinent, they're not hungry or thirsty, that they're not having pain, that we're repositioning them every 2 or 3 hours. Okay. Name 4 ways we can assess confused patient who is unable to communicate their needs. We talk about the 4 Ps, but basically, are they oriented, right? Times 4. Person, time, place, or situation. You can ask, what are you here for? What's your name? What's today's date? Who's the current president? Those 4 questions will tell you whether the patient is oriented times 4, right? But communication with resident and trying to figure out whether they're oriented or confused is going to be important for us as CNAs and nurses to prevent these falls from occurring, right? Okay. Name 5 interventions to prevent fall or techniques to decrease incidence of falls. We talked about this earlier. Bedside commode, having bedside commode is one of them. Elevated toilet seats is one of them. Increase your communication with resident. Frequently talk to them and ask them, what else can I do for you, or can I take you to the bathroom? Are you hungry or whatnot? Mobility aids if they need it, right? Having some mobility aids available. Walkers. Night lights is another one, right? Eyewears and hearing aids if they need it. Make sure you have that. We'll talk about grab bars, how important that is, right? And then, and maybe putting the patient to checks every 15 minutes, every 30 minutes, every hour, whatever the case may be, right? Bring that patient closer to the nursing station is another one. Okay, so those are things that we can do to prevent a fall. I know it was one of those, or sometimes it's a losing battle. No matter what we do, feel like the patient's gonna fall. We're doing certain things, and there's not enough people in our hallway, and you can leave this resident that's on, high risk for falls, and not much we can do. But communication is important. Talk to your resource nurse or the nurse that's on the floor if you have to take a break, and keep an eye on that resident, right? All right. Any questions, guys? Okay. All right, let's go ahead and stop.